I'm a nurse, that's what I'll be. Ain't no one else like me, I'm a nurse.
Morning, noon. Welcome to my channel. My name is NP Ash. Some call me the professor. Head, eyes, ears. On this channel, we will discuss all things nursing, any and everything you want to know about nursing. You have your aortic. Subscribe, like, follow along. This is the Ash Vantage. Hey guys, welcome to my channel. This is the Ash Vantage, where we will discuss all things nursing. Today's episode, we will discuss the physical exam. Now, in nursing, there are two ways you can really conduct your physical exams. You can go head to toe, or you can go through body systems, starting with neuro, then cardiovascular, respiratory. However you feel most comfortable. The most important is that you find a system that works for you and you stick to that system. When we discuss assessments, there are 4 elements to an assessment. In nursing, there is the assessment where you are just looking. Then you have the auscultation where you are listening. Then you have the palpation where you are touching and feeling. And then you have percussing where you are tapping different areas. So those are the 4 elements that you will need to know in order to complete a full assessment or physical exam. I learned, and I particularly like to go head to toe. I will show you an exam from head to toe. Now, I want to break it down. I don't want to just go through and do a head to toe assessment. So I'm going to do the head, eyes, ears, nose, and throat. Then we will move down and we will do the cardiovascular, the respiratory, the abdomen, gastrointestinal, and then we will move on through musculoskeletal. So it will progress from head to toe, but I do want to break it down into smaller tidbits so that maybe it's easier for you to consume and to store. Okay, and let's get started. So welcome back. We're going to start with the general survey. The general survey is what I'm looking for when I initially walk into the room before I've even said a word to the patient. As I'm walking in, I'm cleaning my hands, and I am just assessing him. I'm wanting to look for how he's dressed. I'm wanting to look to see if there's any facial expressions that appear to show distress or anything of that nature. If there's any notable bleeding or big bruising. These are all the things you look for in a general survey. Patient appears calm, he seems appropriate, he doesn't appear to be in any distress. That will be your general survey. So then you will start with a head when doing a head-to-toe assessment. Of course, you always wear gloves when touching a patient. That's just part of your standard precautions. Do it for every patient and then you will never have a problem. So I am going to don my gloves and I'm looking at the patient's head. Head appears to be normocephalic, so it is a normal shaped head. Eyes seem symmetric, face is symmetric. I'm looking at his hair. Their hair is evenly distributed, salt and pepper color. From the assessment, we are going to palpate. There's nothing to listen for on the actual head. So we're going to palpate his scalp. I'm not feeling any lumps, bumps, or bruises. I don't see any infestation as we're going through his hair. That is your head assessment. Okay, moving on to the eye exam. For the eye exam, you will need your pen light. You're looking for inspection, as we always start our assessments with inspection. When you inspect, you're looking at the eyes, you're looking at the size, the shape, you're looking for any redness, any drainage, any swelling. You want to notice the structures, the upper eyelid, the lower eyelids, the iris, the conjunctiva, the sclera. Then when it comes to the actual assessments, there's you can palpate around the eyes. You're searching for any tenderness with palpation or anything of that sort. Then when you go to your eye exam, you would use your pen light. You'd bring the pen light in from the side of the eye and shine it into the eye. What you're looking for is that as you shine the light into the eye, that the pupils constrict or get smaller. As you shine the light on one eye, you'd also want to then look also at the other eye, because as it constricts on one side, it should constrict on the other side. And that is called consensual. You'd want to then check your accommodation. As you check accommodation, you would bring an object out from the patient, say, follow this structure with your eyes only. As you bring the light in or the structure into the nose, you want to make sure that the eyes converge or they both go toward the item. And as they converge, you also want to make sure that they constrict the pupils. And as you bring that item back away from the nose, you'd want to note that the eyes both follow equally and smoothly, and then also that the pupils dilate or get bigger as you move the item back. Now that would be Perla. Pupils are equal, round, reactive to light and accommodation if they're all positive. For the extraocular movements, you would have them follow your pen light and you take them through the cardinal fields of gaze. And as you do that, you're making sure that the eyes move together, that they move smoothly, and that there's no shaking. And so we are looking for nystagmus. And if they move equally smoothly, you can say extraocular movements intact. And that would be your eye exam. So for the ear assessment, it's nice still to have your pen light. Do you actually have to have it? No, but you have it, so I like to use my pen light. When you're looking at the ears, again, we always start with assessing, and we're looking to see if they are about the same level across the face. And they do appear to be equal in size. Then we move on to palpate. And does this cause you any pain or discomfort?
No.
They're soft. I'm not seeing any bruising. There's no pain. I use my pen light to kind of look in the canal. I'm not seeing any drainage or bleeding. We do the same on the other side. We like to palpate first. Any pain or discomfort with this one? We look around. We look inside the canal. There is some hair there, but there is no drainage, no bleeding, or any deformities noted. That would be your ear exam. Okay, so we're going to move on to our nasal exam, and I still will use my pen light for that. When we're looking at the nose, as always, we start with the assessment, and then the nose, there are no deformities that I see. It appears to be midline on his face. So I'm going to go ahead and take a look up. I'm going to look inside your nose. When we look inside the ears, we are looking for any drainage. We're looking for any polyps, or the septum is midline. We would like to palpate. Do you have any pain here?
No.
We're looking for sinus tenderness. This is the ethmoid sinuses. Any pain when I press up here?
No.
Frontal sinuses. And then we also have any pain as I press around here?
No.
Maxillary sinuses. And that is your nose. Moving on, we have done the head, eyes, ears, nose. Next would be the throat, okay? So you'll still have your pen light. As usual, if we're going with the throat, we will start with the mouth. We take a look, the mouth, and it looks appropriate. I don't see anything that's jumping out on me. With that assessment, I'm going to have you go ahead and open your mouth. Can you stick your tongue out, please? Now say ah. I'm looking, okay, thank you. I'm looking to see if the uvula raises midline when I ask him to say ah. The mouth, it is moist, it is pink. We have fair dentition. Okay, we are gonna then we are going to palpate. Okay, I like to palpate the lymph nodes and feel around the neck. We have the pre-auricular, post-auricular lymph nodes. We have the anterior cervical chain, we have posterior cervical chain, we have submental. There are more. I just do a nice palpation through here to feel the lymph nodes. I'm looking for lymphadenopathy, meaning abnormal lymphs, if they're enlarged or anything of that sort. And I did not notice any of that on this patient. With the patient, you want to make sure, can you turn your head to the left for me? Can you turn your head to the right? Put your chin to your chest. Patient appears and you can lift your head. Patient has a full range of motion noted. So there does not appear to be any nuchal rigidity. And that would be your throat examination. Moving on to the cardiovascular exam. For the cardiovascular exam, you will need your stethoscope. When we start, we would visually inspect and assess the chest. We would be looking for any lumps, bruises, scars, anything of that sort. That's what we would visually be inspecting the chest for. From then, we would move on to auscultation, where we would be listening for our heart. You're going to listen into the 5 areas. You have your aortic, pulmonic, Erb's point, tricuspid, and the mitral. APE, A-P-E-T-M, ape to man. You listen for your S1, S2, that lub-dub. If they are audible, you can say S1, S2 audible, positive S1, S2. You're also looking for the rate and rhythm at which it is beating. Is it regular? Is it fast? And you'd want to make sure you make note of that. It was a regular rate at a regular rhythm. And from there, also part of your cardiovascular exam would be your capillary refill. And that's when you want to look at the patient's hands, you want to press, and you want to make sure that when it blanches but comes back in less than 3 seconds. So cap refill is less than 3 seconds. The other thing that can go into your cardiovascular assessment is you can look for swelling, edema, things of that sort that would then actually fall into the cardiovascular exam. I tend to look for that when I do my musculoskeletal, when I move down to my legs. But just so you know, that does really fall into the cardiovascular. The other part would be your pulses. So you'd want to check for radial pulse. And it's just to see 1 plus, 2 plus, 3 plus, 4 plus. And I would say this is 2 plus. And you want to do the same on each side because you want to make sure that the pulses are equal. So you have radial pulses, brachial pulses, popliteal pulses. You have a pulse on the top of the foot, which would be your dorsalis pedis, and you have one right behind the ankle, which is your posterior tibialis. You also, of course, have the carotid pulse as well. The respiratory exam, of course, again, you will need your stethoscope. Now, we've already visually inspected the chest prior to doing the cardiovascular exam. With the respiratory exam, because we also listen anteriorly in the front and then we listen posteriorly, that's when I take the opportunity to visually inspect the patient's back, okay? And so I would like to lift the shirt. I will visually inspect his back. Again, I'm looking for any bruising, any lumps, any moles, any things like that, because you really want to take a good look at the patient's back, because oftentimes they may not have anyone else to look at their back and they can't see it themselves. So if you notice any moles or things like that, you want to make sure that you take a note of it, mention it to the patient, and it might be something to keep an eye out on to make sure it does not have any changes on future visits or things of that nature. So with the respiratory exam, we've already inspected or assessed. Now we're going to move into our auscultation. I always listen to the front first. Can you take a deep breath in for me and out? Again. Then I'm going to move to my lungs. So I listen to 2 spots anteriorly And then I'm gonna go to the posterior back. Again, deep breath, out. Again. Good. What I'm doing is actually I'm going on the back in this motion because I want to compare side by side in the apices of the lungs. And as I move down, I'm comparing side by side through to the bases of the lungs. 6 points. Then you also want to hit the side of each. One of your lungs has 3 lobes. Do you know which one that is? It's going to be the right, okay? So, but you listen, of course, on each side. And that would be your lung exam or your respiratory exam. We have already inspected our chest area when we did the cardiovascular exam. So we've already done that. If we really didn't look all the way, we would take the opportunity to assess the abdomen first. You never touch it first. You'd have them raise their shirt. That would be it. And you just inspect. From there, you'd want to make sure you auscultate. You must always auscultate. Listen to the abdomen before you lay hands on the abdomen. Okay, so with the abdomen, I'm just gonna raise your shirt here. You wanna notice the umbilicus. That is your starting point. You'd want to divide the abdomen in 4 quadrants. Write down the umbilicus, and that's gonna give you 1, 2, 3, 4 quadrants. You want to listen in each quadrant. You are listening for your bowel sounds. If they are hypoactive, hyperactive, or normal active is what you're listening for. If let's say you must listen for 5 minutes in each quadrant before you can truly say your bowel sounds are absent. So unless you've listened for 20 minutes in this abdomen, you cannot say that there are absent bowel sounds. So if you don't listen for 5 minutes, then it would be, but you really don't hear bowel sounds, it's gonna be hypoactive. Then from there, you'd wanna palpate. We have light palpation, and you're just gonna touch around here. You're feeling for any abnormalities, is there any pain or discomfort for you? And then you wanna do a little bit of a deeper palpation, and you're looking for any pain or discomfort for your patient. The abdomen is soft. There's no tenderness as I'm palpating. And then I like to percuss. And that's where I take 2 fingers from my dominant hand and I am striking 2 fingers on my non-dominant hand. I'm listening for dullness, tympany, and any other sounds. You should hear more dullness over organs and things of that sort, and then you would hear more tympany in areas that are open, hollow, gassy, things of that sort. And that would be your abdominal exam. So then we have our musculoskeletal exam. On the musculoskeletal exam, I did not see my patient get up, walk around. However, I have noticed my patient being able to move his arms and things of that sort. But I'm going to go through a few of the tests. With the musculoskeletal, we're testing for strength, grips, pushes, and pulls. Can you grab my fingers, please? Please, tight as you can. Now you can notice, you want to do what you do to one side, you want to do to the other. My patient cannot fully make a fist on the right hand, and the grip is really strong on the left. So I would say a 5 out of 5 strength on the left. I'd probably say about a 3 out of 5 strength on the right, okay? And limited range of motion noted to the right hand, as he could not fully make a fist, okay? Now, go ahead and put your arms up like this. Don't let me pull your hands away. I'm pulling, very strong, I could not. Now, don't let me push them towards you. Oh, good. Strength, as far as the pushes and pulls, those 5 out of 5. Okay, now, can you lift your knees for me? Bend your knees. Good, nice and strong. 5 out of 5 there. I'm going to, can you step on the gas pedal? Both feet. Good, good. Nice and strong. And pull your toes back towards you. Very strong. I would say pushes and pull in the feet. Also 5 out of 5. So his upper and lower extremities, would be a 5 out of 5. However, when it comes to the hands, I would say a 3 out of 5 in the hand grips. Okay. From there, I also like to, if they have on pants, I always pull the pants up a little bit. And here, I just want to feel I'm looking for edema. I'm checking skin turgor. Skin turgor is good. I don't see any obvious, there's some old wounds, all well healed, no signs of infection. Okay, no signs of edema, even with the socks you can notice. I would also take this opportunity to remove my patient's shoes and socks, because we check pulses in the upper extremities, but we did not check in the lower extremities, because I like to kind of do things, work my way down and only have to do it once. So I'm doing that dorsalis pedis pulse, the posterior tibialis pulse, and I'm going to check cap refill in the toes. I'm also going to take a look in between, especially for our diabetic patients, and do the same thing on the other side, of course. Checking for that dorsalis pedis pulse, that posterior tibialis pulse, our cap refill, checking in between for any unnoticed ulcers or things of that sort. We're checking our toes, our nails for also any fungus or things of that nature. Then we will put our patient back together for comfort. And that is your musculoskeletal. In the end, you want to go ahead and you want to doff or remove your gloves, hands and tie. I hope this was helpful as we broke down each step of a head to toe assessment, and I hope it helps you in school. Thanks for tuning in. Come on back, subscribe, or like the Ash Vantage.
I'm a nurse, that's what I be. Ain't no one else like me, I'm a nurse.